Hello, my name is Hannah Carpenter and I'm a PhD student at the University of Texas Medical Branch in Galveston, studying bioethics and health humanities. The opinions reflected in this presentation today are those of my own, and I have no conflict of interest. In this presentation, I'm going to discuss women's access to contraception under the Affordable Care Act and what this means following the Supreme Court decision in Dobbs v. Jackson Women's Health Organization. To give you some background, access to contraception has historically been viewed as a fundamental healthcare right, as it allows women to control their bodily autonomy and allows women to have personal, financial, and social freedom. In 2012, the Affordable Care Act required insurance companies to cover FDA-approved contraceptive methods without cost sharing, with the goal to make medical care more affordable. Whilst it has achieved this in some aspects, having private health insurance in the US still does not guarantee full and affordable access to contraception. And although half of the women in the US have private healthcare insurance, 1/3 of women still pay out of pocket for their preferred method of contraception because the federal rules do not require healthcare insurance plans to cover every single contraceptive type without cost sharing. Although the Affordable Care Act generates several restrictions to women's contraceptive rights, including religious and moral exceptions to contraception, which has been widely reported in the literature, this presentation will solely focus on the restrictions relating to the choice of contraception imposed by employers and insurance companies. Further, there may be other considerations for Medicare programs regarding contraception access. However, this goes beyond the scope of my presentation today, and I will only be talking about the restrictions imposed on those with private healthcare insurance. I will argue that the Affordable Care Act should be updated and greater consideration is needed for women's reproductive autonomy, following the US Supreme Court's decision in Dobbs v. Jackson Women's Health Organization, which has removed the constitutional right to an abortion and placed restrictions on abortions in over half of the states in the US. This decision has placed a heightened importance on access to contraceptive services nationwide, as contraception is now one of the only methods to combat unwanted pregnancies. I will conclude that the Affordable Care Act, as it stands, is not sufficient enough to protect women's access to affordable contraception in a post-Dobbs world. This is a snippet from the FDA birth control guide listing the 18 types of approved contraceptive methods on the left-hand column. The other columns demonstrate the number of pregnancies expected from each contraceptive type, as well as the use, the risks, and the side effects. The Affordable Care Act stipulates that private health insurance plans must cover at least one contraceptive product from each category of the 18 FDA-approved contraceptive methods without cost sharing. This includes 3 types of oral contraceptives, the contraceptive injection, vaginal rings, cervical caps, and IUDs. To note, this does not include male condoms. This requirement allows for restrictions to be imposed by insurance companies and employers that limit women's access to contraception. Firstly, the cherry picking of contraceptive products. As the Affordable Care Act only requires that insurance companies cover at least one contraceptive product out of the 18 FDA-approved methods without cost sharing, insurance providers are free to choose which contraceptive products they want to provide without cost sharing in their plans. For example, there is a requirement to cover each of the 3 oral contraceptives: the combination pill, the progesterone-only pill, and the continuous use pill. Oral contraceptives are one of the most popular birth control methods in the US, and there are many options for women to choose from. There are currently over 250 birth control pills available that have a plethora of different side effects. These include mood changes, weight gain, and nausea, and the reports of these side effects differ across different methods and different products. This flexibility, allowing insurance providers to choose what products are covered in their plans without cost sharing, allows them to have control over the products that women can choose from. This may limit women's choice if they cannot pay out of pocket for a product that suits them and it is not covered by their insurance plan. Insurance coverage changes. Women are also subject to their employer changing their insurance coverage during the course of their employment. With this, the type of contraceptive coverage available for them may also change, making it more difficult for women to stay on their chosen contraceptive. For example, an insurance provider may stop covering a branded product and switch a patient to a generic version instead, which may have different side effects. Insurance provider approvals. One way that insurance plans have made it difficult for women to access certain type of contraceptives is by requiring that their healthcare provider obtains approval from their insurer first, often by requesting documentation to prove that the product is medically necessary, and sometimes asking for reasons why a different contraceptive method that is covered without cost sharing cannot be used or hasn't been previously tried. The appeals processes. There are some exceptions that have been set out in the new FAQ guidance that was released in July 2022, prepared jointly by the Departments of Labour, Health and Human Services, and the Treasury. An individual or their medical provider can now use the exceptions process to access a specific product that is not covered by their insurance without cost sharing, if their medical provider deems it medically appropriate. The guidance sets out that the exemptions process must be easily accessible, transparent, and sufficiently expedient. The meaning of these terms has not been set out in the guidance, and it may have been left intentionally ambiguous. However, according to the National Women's Law Centre report, many patients and their healthcare providers aren't even aware of these processes, so women are still paying out of pocket for their birth control. Additionally, this can cause time constraints. The need for birth control can be time sensitive, and waiting for insurance companies to process exceptions or approval requests can be timely and cause irreversible consequences for women, particularly for those women who live in states where abortion is now criminalized. These restrictions generate a variety of ethical issues. This includes the restriction of bodily autonomy. Bodily autonomy allows women to have choice and control over their own body. However, the restrictions generated in the Affordable Care Act restrict this for women. Contraception is and should be a very personal choice, and there are many reasons why a woman might need a specific type of contraception. For example, some women may need a contraceptive that has a higher or lower estrogen dose, or need to switch birth control due to negative side effects. What meets one woman's needs may not meet another, as women can respond differently to hormones in various birth control products. These limitations evidence the false sense of autonomy that is presented to women regarding their contraceptive choices. The restrictions can also generate class-based discriminations. Limiting cost-sharing options generates class barriers to accessing contraception. Should a patient wish to choose a product that is not covered in their insurance plan because it has lesser side effects, for example, they may suffer the out-of-pocket costs of choosing a contraceptive product without these side effects. This leaves women with the difficult choice of choosing between a contraceptive that may not be right for them or paying out of pocket for one that is. Some women may be without this choice entirely if they cannot afford the out-of-pocket costs. This also undermines the role of the physician. Requiring insurance provider approvals before a physician can prescribe certain types of contraceptives undermines the role of the healthcare professional and second guesses their determination that a specific contraceptive product is appropriate. It is worth noting that this issue is part of a broader problem for treatment options across the US and affects access to all kinds of therapies. Finally, avoiding becoming pregnant may be a top priority for many women in the US following the criminalization of abortion. The implications of DOBS are likely to increase the number of women requiring contraception since they are now unable to control their access to safe abortions in states where abortion is criminalized, and contraception may be the only option for women to combat unwanted pregnancies in these states. In light of these issues, the Affordable Care Act should be updated. The current policy restrictions place unfair and arbitrary limits on contraception, which should be a personal choice. I argue for expanding contraceptive access under the Affordable Care Act to ensure greater access to contraception post-Dobbs. Revising the Affordable Care Act will allow for full coverage of all FDA-approved contraceptive methods without cost sharing. There would be no restriction or unnecessary barriers to contraception access, and decisions about contraception would be determined solely by the doctor and the patient without any interventions from insurance providers. Further, the requirement to cover at least one form of contraception within the FDA-approved contraceptive methods is specific to women's contraceptive methods and excludes those affecting males. While sexual health screening is required to be covered by insurance companies, the policy currently excludes vasectomies and male condoms. Many healthcare providers recommend that male condoms are used as part of a dual process regimen to be paired with a contraceptive prescription method that provides more reliable pregnancy protection. Expanding contraception access for men and providing a wider and more equal healthcare policy that incorporates both genders would be beneficial for both men and women in providing access to preventative measures. These revisions to the Act would allow individuals to have equal access to reproductive care and broader autonomy over their contraceptive choices, which is particularly important in an environment where controlling one's own reproductive autonomy has become increasingly more challenging. It could be argued that expansive contraception access may place excessive financial burdens on public healthcare resources. Some may claim that the estimated cost of contraception could far outweigh the benefits when money dedicated to healthcare resources could be put to other use. However, broadened access to contraception has already been achieved in some states and could be used to model a new federal system that protects all women's healthcare rights. For example, New York has the most expansive policy in the United States regarding women's contraceptive access. The Comprehensive Contraceptive Coverage Act of 2019 allows women to have access to nearly all contraception coverage at no cost and with no restrictions or delays. This was enacted to improve timely and affordable access to contraception. I note that the political differences between states that currently outlaw abortion may preclude the same policy from being adopted across the whole of the United States. But perhaps it would be more plausible for the federal government to adopt the New York policy as a model for revisions rather than applying the same model to all individual state governments. Secondly, making revisions to any federal policy is challenging and timely. Therefore, I think the first step should be to raise awareness surrounding the exemptions process and require insurance plans to provide information on these processes to enrollees and healthcare providers so that women can understand the different ways to access contraception in a post-Dobbs world. Access to contraception impacts everyone who is a potential parent, and equal and unrestricted access to reproductive health care is therefore central to everyone's self-determination, and the freedom to control one's own family building is a widely accepted value in most societies. The choice whether, when, and how to have children is central to people's identities, as well as their social, personal, and financial freedom. This should be a decision that individuals can make about their own life. An individual's economic status is heavily influenced by having children, which can be a barrier to economic mobility. Now that contraception may be one of the only options to combat unwanted pregnancies, unrestricted access to contraception is paramount. This issue highlights a bigger problem within the US private health insurance-driven model of healthcare that impacts all sorts of therapies. Updating the ACA to ensure broader access to contraception is the first step towards access to equal reproductive health care in the United States. However, there should be a larger push for increased funding for access to basic and preventative care for all US citizens. For example, in the United Kingdom, all individuals are entitled to free public health care through the National Health Service. Should a similar model be eventually adopted in the US, this would better facilitate equal and affordable access to care and mitigate the numerous health disparities that currently exist. While the implementation of a public healthcare system would be complicated and challenging in the US, A shift from a private insurance-based system to one that is universally inclusive would offer substantial benefits for every type of citizen. Shifting the landscape of reproductive health would benefit public health overall, because reproductive justice is a public health issue that needs to be accounted for, and this is crucial in light of Dobbs. Please find a list of my references here. And please do get in touch if you have any questions or would like to discuss this topic further. Thank you.